My name is Gail Wright, and I am the president of the Canadian PBC Society, a support group for PBC patients and their families. Our group is a registered charity completely run by volunteers, many of whom have PBC like me. I would like to thank all of you who have made donations that support all of our programs throughout the year, and I would like to recognize our series sponsors, Intercept Pharmaceuticals and Simibae Therapeutics. Tonight's guest presenters are Dr. Hin Hin Ko and Dr. Ed Tam. Both Dr. Ko and Dr. Tam practice in Vancouver and specialize in liver disease with a focus on autoimmune liver disease. So to get things started, I'd like to turn things over to Dr. Tam.
Great, thanks a lot, Gail. It's a pleasure to be able to do this presentation with Hin Hin, and we're going to kind of trade back and forth as we go along. Topic for today is focused on PBC diagnosis and management to start, but obviously we wanted to keep it pretty current, and so a significant portion of today is going to be talking a little bit about COVID in the liver, and then specifically COVID vaccines and the liver, obviously an important topic. So I'm just going to get my screen shared and we'll get started here. Okay. All right. So just starting a little bit on the general topic of PBC. We think of it as one of these rare common diseases. As liver specialists, Hin Hin and I, we see it, quite frequently. But even for someone such as myself who, manages liver disease day in and day out, I maybe only manage, actively 100 or so PBC patients at a time in my clinical practice. So while I see a fair amount of it, of course, it's still one of those conditions that's not quite as common out there. Now, we think about PBC more commonly occurring in women and, of course, in that 40 to 64 year age group. But, of course, we see it affect individuals across ages and not just women, of course. And it's really an important liver condition that we keep in our minds on the differential anytime we're seeing by anybody for any chronic liver disease state. And of course, we think of PBC as a chronic and potentially progressive autoimmune liver disease. And for a lot of individuals, it starts with the understanding that they are anti-mitochondrial antibody positive. And this kind of varies a little bit in clinical presentation. I think that in practice, certainly I see individuals that for whatever reason have been found to be AMA positive, and yet they have normal liver tests. And the question comes up often, should and how should we monitor individuals? But perhaps more frequently, we see individuals come into the referral pathway with abnormal liver tests such as alkaline phosphatase that requires further diagnosis and investigation. And that's how we often come to understand people may have AMA positivity or establish a diagnosis of primary biliary cholangitis. When you look at the steps when we think about the disease progression that can occur here, certainly, as we move through the serologic changes such as antibodies to the biochemical changes such as elevated alkaline phosphatase, we eventually can see changes under the microscope as well, of course, reflective of cholestasis. And then over time, in some individuals, the level of liver disease can become significant enough that we start to see clinical manifestations or complications of liver disease, manifestations of portal hypertension, things such as ascites or variceal bleeding. And it is true that some individuals with PBC can progress to significant enough liver disease that they may require liver transplantation, of course. And our job is always to try to diagnose the disease early, to treat it early, and to ensure good and safe long-term outcomes for everybody that we can. Now, if we think about the patient journey, getting back to how we may follow somebody through the journey of diagnosis into treatment and management of PBC, which will kind of be our focus today, we can maybe discuss this in the context of an example case. So, most patients with PBC do have abnormal liver tests, and that's frequently how people come into the referral pathway, as I mentioned. A primary care physician may screen an individual for whatever reason, whether they have symptoms or not, check their liver tests. And in this case, Lisa's a 59-year-old woman who's referred for persistent alkaline phosphatase elevation and a positive anti-mitochondrial antibody result. And here you can see in this example, laboratory investigations at baseline, which are pretty representative for somebody who may present as such, with an alkaline phosphatase about 2 times the upper limit of normal, relatively normal hepatocellular liver enzymes, that is the ALT and AST, bilirubin in this case, that's in the normal range. And as you can see in this case, in this example case, we have liver biopsy data showing bile duct inflammation, focal bile duct proliferation, and findings essentially under the microscope that are consistent with primary biliary cholangitis. Now, as we'll discuss, we don't do biopsies in all of our individuals with suspected PBC. In fact, we do biopsy relatively infrequently now, but biopsy still is used in some occasions from a diagnostic perspective. And here we have that data. And then here we also see in this example case, this patient's sister was diagnosed with PBC by liver biopsy in 2003. So there's a little bit of that family history. So thinking about establishing the diagnosis, the individual that I just presented had abnormal liver tests, AMA positivity, and histologic evidence under the microscope consistent with PBC. And of course, that forms the three major diagnostic criteria for this condition. But to confidently diagnose PBC, you don't need all of them. 2 out of 3 would be considered sufficient from a guidelines perspective, and certainly from a clinical practice perspective as well. I think if you look at how clinical practice has evolved over time, I think we're seeing fewer and fewer biopsies done for PBC in general. And I think that's for most of us, we're very, very confident, of course, just as the guidelines suggest, to establish a diagnosis based on the presence of anti-mitochondrial antibodies and, of course, abnormal liver tests in a relatively specific pattern of cholestasis. Now, of course, there are other conditions to keep on the differential, as there are always when investigating chronic liver disease. So the typical circumstance when we see an individual in whom we suspect PBC is, of course, to still cast a wide net and to look for other cholestatic liver diseases that may be present or overlap with other chronic liver disease states, such as fatty liver or otherwise, which we're seeing more and more commonly these days. As far as how an individual may present from a symptom perspective, well, the common clinical features, fatigue, pruritus, which can be pretty significant and in some cases really impactful on day-to-day life. Other less specific findings, sometimes right upper quadrant discomfort. We do screen individuals at baseline with respect to their bone density and look at their lipid profile. And there are some findings on physical examination that can kind of key us into the possibility of a diagnosis of PBC. When we think of Lisa, who presented with abnormal liver tests and positive anti-mitochondrial antibody status, her past medical history includes osteopenia or reduced bone density, hyperlipidemia, and fatigue. And this would be a pretty common backdrop upon which we may diagnose somebody with PBC these days. So fatigue, of course, is a really difficult symptom, I think, in this condition. And perhaps we'll have more discussion about this as we go along in this session. But the difficult thing with fatigue and PBC is sometimes it persists, I think, despite adequate treatment for the underlying condition. And I think there's certain conditions we like to think about and to rule out that may be contributory to fatigue. Over and above that, when we talk about trying to manage fatigue in the context of PBC, this is really challenging. And I remember Hin and I had presented on this topic in the past before and had asked each other what we're doing. And to my recollection, neither of us are really using much in the way of pharmacotherapy, such as modafinil these days. I think physical activity is important. And I think certainly we like to encourage physical activity. And it's interesting, there have been some more recent pilot studies looking at high intensity kind of interval exercises that you can do in your home that actually may have an impact on fatigue levels in PBC. So I think over time, we'll start to get a little bit more information about the types of activity and the kind of structured activity that may help with fatigue. And in the meantime, I think we're still looking for better answers as far as how to address this often challenging symptom. Itchiness or pruritus is another one that can be very challenging. Treatment of PBC doesn't always come with an alleviation of the pruritus that accompanies it. And so sometimes, of course, we need to think about specific treatment modalities for the itchiness itself. When you think about pruritus and PBC, the etiology or what causes it isn't really well known. There's a lot of postulates as far as what the pathophysiology may be, as far as why people get itchy in PBC. But to be fair, nobody knows for sure, and there's probably multiple pathways which affect it. It seems to be more intense in the evenings and commonly located on the soles of the feet and palms of the hand. But of course, for any given individual, the way itchiness presents can be a little bit different. when we talk about management of itchiness in PBC or pruritus, obviously there's general recommendations, and then typically we move through pharmacotherapeutic options, medications that help with itchiness in a certain way. Cholestyramine is a medication that works, and I think we often use first line. The difficulty is it often causes gastrointestinal side effects. So for some individuals, it can be hard to tolerate, and you have to dose it in such a way so that it doesn't interfere with other medications that are taken. So sometimes it does complicate individuals' medication regimens if they're taking a number of other agents. So second line agent that we often use, and I use a lot in clinical practice, is rifampin, and I think the side effect profile is pretty well tolerated there, and it works quite well. Beyond that, things like naltrexone, sertraline, gabapentin can be used, and I think there's a lot more clinical and practice-to-practice variation with respect to where practitioners go after the more common starting points of cholestyramine and rifampin. But pruritus is one of those symptoms that sometimes it takes a little while to really get it right when it comes to the approach to management. And it can be something that really affects, again, quality of life. So something that we really like to try to help along with if we can. So lots of options, but a lot of times we have to kind of try different things to find the right solution for a given individual. Heenan, are you using anything else, other than kind of what's up on the screen that you're finding works much, or are you kind of
I very similar approach, but after talk to some other people, maybe more with the new drugs like the fibrates. I haven't used it, but I'm kind of like keen to start using the fibrates as still has its own side effects, but probably is one of the drug that I'm very keen to try when the next person have really bad itchiness. But I basically follow the same protocol. I use the cholestyramine, and I have some good success with naltrexone, but then there's like the cost, and it goes through the same, some drugs that some person just never really respond to any of those drugs, that maybe liver transplant is an option. They were that bad, but I guess, yeah, I think everyone is different. We have to just try different options.
Yeah, I think the fibrates thing is interesting. I haven't really used much myself, but of course, anecdotally, people talk about getting a good response from a pruritus perspective. So I agree. Moving on to other clinical features of PBC, we talked a little bit about the effects on bone density and the fact that we do like to screen individuals with baseline bone densitometry and recommend vitamin D supplementation for sure. Typically calcium as well, dependent on your dietary intake already and whether you're confident you're getting enough. Sicca syndrome associated with dry eyes and or dry mouth is common as well, and often something that we look out for. Hyperlipidemia, it's an interesting one. We see it as a pretty clear relationship, but we don't really have a lot of data or significant data at all that suggests an increased risk of cardiovascular disease in that context, which is reassuring, of course. Thinking about, management of other issues, when it comes to Sicca syndrome, obviously, there's specific therapies that can be used to address dry eyes and dry mouth, as it is. And this is something where, personally, I often may ask for a help if symptoms are significant in that regard, rather than managing Sicca syndrome myself in this clinical context. And now we kind of get to the meat of management with PBC, and that's kind of thinking about, after establishing a diagnosis, how do you actually treat the underlying disease, of course. And Hinian's going to take us through that therapeutic end of the tree. And before we move there, just looking at, the other side of it, which is really about managing some of the associated symptoms with PBC. This is just a little quick flowchart summary of the things and strategies that are being used in clinical practice to manage things like sicca, fatigue, and pruritus. But with that, I'm going to stop sharing here, and I'll hand it over to Hin to pick up the conversation around treatment of PBC.
Okay. Thank you so much, Ed. I mean, again, it's a pleasure to co-present with Ed, and thank you, Gail, for allowing us to try this method to present and talk to everyone attending from across Canada. So let me see, just making sure that works. Okay, can everyone see okay? Yeah, okay. So I will touch on more the treatment options for PBC. And at the end, I will touch on the COVID and the concern with the vaccines. So we'll go back to the case. So she will get the diagnosis of PBC. So we know that urso, it is the first line of standard of care for all patients. So we started her on the dosage twice a day based on her weight. So usually we take a dose between 13 to 15 milligram per kilogram per day. Now, why urso? So it is actually a natural bile acid that's present in our human bile. And normally we say twice a day dosing, but it really can be even once a day if people find it's hard to remember taking the evening dose, for example. But I find sometimes by spreading out the doses help if especially people feel itchy. I have a few patients that got really itchy when they first started the urso, like helping the bowel flow a bit better. So by spacing out the dosing interval, then it kind of take care of that increased itchiness when urso was started. Now, there's no really data to support higher dose than more than 15 milligram per kilogram per day. And how does it work? There's different mechanism. They think because urso is more making the bile acid more water soluble. So basically help to the bile flow a bit better. So kind of reduce the toxicity of this bile kind of like staying stagnant in the liver. But there's some theories say, oh, maybe there's some reverse of the fibrosis make the bile acid less toxic. So what evidence we have to suggest that urso is effective? So they look at many studies. You can see the reference and many papers been published, even the data back in 1997 up to now that urso definitely has lead to a decrease in alkaline phosphatase and also decrease in the bilirubin. And also quite important, as Ed mentioned, that really want to start the treatment early because you can see the graph here that urso, not so you can see the arrow, but you can see the gray bar is when they started the urso right at the beginning. You can see the probability of survival is still kind of much higher than the red line. So the red line is they were on placebo, so not on anything for about 2 years before they started the urso. So a bit delayed in terms of starting the urso. Even they kind of bit of catch up, but it never quite the same curve as the urso. So we want to diagnose early and start treatment early. So we do have enough evidence to show that urso can delay the progression of liver fibrosis. And so that means we can prevent the liver transplant need. Now, so this is again another graph that really shows a dramatic difference that the stage of the PBC can affect the effectiveness of the urso. So you look at the top graph here, the dark red one, so general population, we know that as over time, you do see a decrease in survival. Now the blue line is the patient who began treatment in early stage PBC. So you can say as soon as that person started on urso quite early and being monitored, you can see the survival curve very similar to the general population. Now let's say you pick up the diagnosis when someone already had kind of moderate to advanced stage, there's already some fibrosis, that even you start them on urso, the curve just never quite the same as the one we start early. And of course, let's say if someone got unfortunately diagnosed a bit like advanced stage, already have cirrhosis, even though you put them on urso, that it just never the same, never catch up. So you can see as time goes on, a bigger difference in the survival curve. So it's very important that we put someone on urso, is that we'll start them on treatment. We want to make sure they respond. So there are many different criteria we use. I mean, and this is definitely more relevant when they do study. So some of the common criteria is like the Toronto criteria and then some Paris criteria, but basically look at over time. It depends on 6 months or even 1 year after you on the urso to see, we want to see a drop in the alkaline phosphatase. So example, we use the Toronto criteria, one, the alkaline phosphatase after the 2 years of ursodeoxycholic acid treatment, the ursodiol treatment, we want the alphos to be less than 1.67 of the upper limit of normal. So is someone that still have alkaline phosphatase over like 300 or over 200, even after 2 years of urso, we know that, probably this is a person doesn't have adequate response to ursodeoxycholic acid. We may have to start thinking about additional agents. So what marker we use? We mentioned about alkaline phosphatase. So from all the study, we know so far that if someone had persistent elevated alkaline phosphatase, it does mean that they have a higher risk of need to transplant. So, and then there's some study, really depends on the population. There may be a variation. They said up to 40% of people treated with PBC of the urso may still have elevated alkaline phosphatase levels that put them at risk. Now, the other numbers we look at is the bilirubin. They said, yeah, we know that when the liver not functioning well, most of the time we see maybe slowly rising bilirubin, which could indicate maybe even cirrhosis. So again, we want to see not a rising bilirubin. And the other thing now we have the lesions of checking someone fibrosis. We have fibroscan, we have some of the biochemistry like equation we can calculate fibrosis. Again, it's something we want to monitor for, like if someone on treatment, are there any progression of liver fibrosis that we need to think about, oh, does this person need additional treatment? Now going back to the case, so she has been taking ursodiol for 3 years. So the alkaline phosphatase is 230. Now the last visit, the lowest is like 210, and bilirubin 10.3 is still within normal range, and then got detected of F2 fibrosis. Now, we mentioned that we want the alphos to be less than 1.67 of the upper limit of normal. So roughly, depends on the lab, probably we want the level that means alphos less than 200. So someone should have alphos less than 200 when they're on ursodiol for 2 years. Now, in this case, it looks like that Lisa is not responding. So very luckily we had agent, because for longest period of time, we only have ursodiol. And then there's some kind of like, not approved, there's some investigational use. People talk about using fibrates, but really no Health Canada approved therapy for use for those patients don't respond or don't respond adequately to ursodiol. So obeticholic acid, the OCA or Oclavia, is definitely indicated for patients with PBC used together with ursodiol when they don't have enough response. Or for those patients who just don't tolerate urso, have side effects or allergy, then it can be used as a monotherapy. So in this case, so she was put on oral obeticholic acid, starting at a dose 5 milligram with the plan to slowly titrate up to 10 milligram based on side effects, how tolerable she is to the medications. And she takes it with ursodiol because she tolerates it. It's not like she had allergy or intolerance, so we added on a second agent. So what is obeticholic acid? So it's an FXR agonist. So FXR is a receptor. You find it in the bowel, in the liver. So it's a really important and multiple pathway to regulate bowel acids productions. So as mentioned to the last case, we mentioned this patient is on 5 milligram a day. So at 6 months, if they say, have some response, but not quite to less than 200, and they tolerate it no problem, we can increase to 10 milligram once a day. Now the dosage has to be adjusted. Someone has cirrhosis, quite advanced disease, we have to use a less frequent and lower dose. And but you said, what if someone don't respond to OCA? So they do say, well, go up to 10 milligram. And then even after 1 year on 10 milligram, we're supposed to follow the blood work to ensure they do respond, because there's still possible small number of patients that despite adding the OCA, they just not enough, that maybe even doesn't do anything. We might have to say, okay, weighing the risk and benefit, we might have to stop the OCA and either think about trials or other medications. So how does it work? So basically by agonist mean basically binding to the FXR receptor, the OCA basically can decrease the bile acids production and increase excretion. So think about bile acids as toxic. You want to really excrete them. You don't want to stay within the liver, the bile duct. So what it does decrease production and increase the excretion. So this is supported by very good clinical study and published in good journal, the New England Journal of Medicine. So this is a phase 3 study to show that taking OCA that demonstrate that really helpful. So the gray bar is the someone just taking ursodiol. So it's 6 months later and 12 months later. So the green bar is the one that you add on the OCA. So 6 months, you see that a percent of patient achieving the primary endpoint, which is now they have the alkaline phosphatase less than 1.67 times the upper limit of normal, and bilirubin remain normal. And then they have to also meet the alkaline phosphate decrease by more than 15%. So this, they have to achieve all three things. So when they last longer, take the OCA and the ursodiol combination, you can see by 1 year, you had a higher percentage of patients achieving the primary endpoints. So definitely very promising that by adding on, compared to placebo, you can see a huge difference, like 10% versus 46%. So in general, pretty well tolerated. The most common reaction, I would say, it is the pruritus. So you can see on the table here, so the OCA group, 68% will complain of some pruritus versus just 40% in the placebo. So keep in mind, I mean, as Ed mentioned, that a lot of PBC patients has some background pruritus to start with, and you add this medication, you can expect to see sometime a bit temporarily worsening of the pruritus. The fatigue is there, but the other one's very similar to placebo. So usually how we manage is we lower the dose. I mean, it's like, it does come in 5 mg. What I do in practice, sometimes I just take every other day or even every 2 days. So start out with really low. And of course, we use all the measures we talk about to maximize like non-pharmacological and other measures to help with their itchiness. And then just really gently titrate up the dose. Most of the time, it's just like very short term. I think after a while, most of the time, I'm not sure you can argue they got used to it, but most of the time the pruritus got a bit better after they're on a stable dose of the medications. Now, a recap. So comprehensive treatment of the PBC, we do want to treat early. And the ursodiol, it is the first line treatment. Now, but keep that in mind that not all patients have adequate response. So we don't know if they don't have response because they don't really have too much symptoms. And symptoms sometimes don't correlate to the response. So very important, we need to do some blood tests to monitor them, like specifically the alkaline phosphatase and bilirubin. Now, OCA, the obeticholic acid, now is available that we can use for those patients who don't have adequate response to ursodiol. And especially those patients just don't tolerate it, we can consider using as a monotherapy, just like the only agents. So now we have a second line option we can use. So again, also, this is the main treatment of PBC, but we, as Ed mentioned, we want to manage the other symptoms and together, like help our patients. So moving on, something exciting about the PBC. Now we already have like, OCA, we haven't talked it for a while. Is talk about being like creative, different combinations or maybe new drugs. So as I alluded to, the fibrates. So this paper published a few years ago is to look at adding one type of fibrates, the bezafibrates. The other one that we have been also look at is the fenofibrates. So they have kind of the PPAR agonist, so works a little bit differently than the FXR and the URSO. But again, it's shown promising results. So you can see the blue line represent the placebo. The orange line represent the patients on bezafibrate. So it's a placebo control. So basically you can see that the one on placebo, yeah, not much change to alphos, but then if they got the bezafibrate added, you can see a decrease in the alkaline phosphatase level. Similarly, for the graph B, total bilirubin, you can see a drop. And furthermore, the bottom, the graph D, looking at liver stiffness. So by adding the bezafibrate, it looks like over time, even after 2 years, in general, they seem to have a lower liver stiffness. But this is measured by the FibroScan. It's like a machine, kind of like an ultrasound, but give you like a waveform. The test that can be done within a few minutes to tell us the stiffness of the liver. So we want to be less stiff. When it's stiff, it means some scar tissue. But again, seems like by adding the bezafibrate versus nothing, it definitely helped to decrease, make the biochemistry better and potentially have lower liver scar tissue progressions. Now, even more interesting, because I kind of mentioned that, well, what if someone don't respond to OCA in addition to ursodiol? So this is just published recently in March to look at triple therapy. So we're talking about a lot of medications, but they would say, well, what if someone, they just on 2 agents, we all add on the third one. So you look at the whole cohort. So look at the top, the entire populations. So you can see the alkaline phosphatase level on the y-axis. And then the bottom one, just baseline dual therapy, baseline triple, and the end is the end result. But you can see the last bar is, you can see the one on triple therapy, you see the lowest alkaline phosphatase level. And then the graph B, kind of interesting to look at the sequence of the agents you use. So first of all, there's someone just on URSO, now add on the OCA, then you add the fibrate. Or then some patient on fibrate first, you add on the OCA. It seems like it doesn't matter, not a big difference, whatever the sequence. By adding, if someone 2 agent doesn't work, you add the last agent, the third agent. All of them seem to further decrease the alkaline phosphatase. Now the bottom graph is to look at the pruritus. So again, we want to be the light orange, that means absence. So again, it seems like by the triple therapy, you see a higher percentage, 66.1%, but with 3 drugs, they have absence pruritus. So you see a lesser portion of patients still have the pruritus. Now look at the B. So first look at the OCA to fibrate. So this is someone on urso, then you add the OCA, eventually add the fibrate. So you can see the baseline triple. So this is the one that's like, after the OCA before, right before they add the fibrates, you can see, yeah, the pruritus is very similar because we know OCA does have a side effect pruritus, but after you add the fibrate, you can see a bigger, lighter orange. The 64% now have basically say no pruritus. So the fibrate group, you can see after the baseline triple is basically immediately you add the fibrate before you add the OC, you can already see the big jump. Seems like fibrate, a signal that it might help with the pruritus. But again, you achieve more people with no pruritus when you have the triple agent. So very interesting. But again, we have to be mindful. This is like 3 drugs, triple agents, a lot of pill burdens to take and potential side effects. But it really kind of proved that there's 3 drugs that was available, not in a trial setting, that we can potentially help someone just have a very difficult to manage PBC. So now moving on, one of the exciting stuff is like all the table listed here is new therapies for PBC in clinical trials. So you can see that they work in different mechanisms. Like the first 2, like FXR, which is very similar to OCA, like almost like a different like newer generations. The FGF19, very similar, they still work along the FXR. Then you have the PPAR, which is like the fibrate kind of like mechanism. So we have seladelpar and elafibranor. So those 2 have been presented in major liver conferences to show very promising results. And then I want to add the bottom here. So this is like, I don't know if you attend Dr. Mason talk, he really believed that PBC as maybe a theory is about infectious virus. So that's actually a new trial, CRA trial, they sponsored a trial, is like to look at antiviral, maybe they have some effects in the PBC. So I want to highlight that because there's some special Canadian connection. Now, really briefly, I don't expect to know, but just to show you, there's some promising that we actually now available clinical trials. So this is the seladelpar, which is a PPAR delta agonist. So you can listen on the left side, you can see, oh, it seems like a lot of good mechanism. Basically, decreased bile acid production, decreased fibrosis, decreased inflammation, and even potentially some metabolic benefit, kind of like decrease the bad cholesterol, the LDL. So there's more than just the bile. There seem to be like a few different other extra benefits. So you can see on the right side, this is what they present in the conferences, is like by 5 milligram. And then the 10 milligram, you can see that's a further drop in the alkaline phosphatase. And the bottom graph to show, which is the extended benefit, you can see a decrease in the gamma GT, the bilirubin, doesn't matter which dose, 5 to 10. The 10 milligram, you see a little bit higher decrease in LDL and the CRP. So again, there may be some extended benefits with these medications. So we'll wait for the phase 3 trial to see whether it confer like long-term benefits. So elafibranor is work on another like receptor, the PPAR alpha, but very similar. This is published in the Journal of Hepatology. Again, just to show you, they used 80 and 120 milligram. So the graph showing the little triangle is the placebo, but the circle one is the lower dose, and the square one is the one on higher dose. But you can see compared to placebo, those 2 definitely see a mean like decrease in alkaline phosphatase extended. And of course, they stop the treatment, kind of go back to closer to the baseline. And then similarly for the means relative change, looking at the percentage, you can see quite a high drop, like minus 40%, even up to minus like 45% drop. So again, showing very promising, but again, they're doing like a further phase 3 trial to confirm, looking at bigger populations. So again, very promising. They have newer drugs potentially may have less side effects. Now, switching our gears a little bit, because this is want to be very timely to talk about COVID-19 and the liver. So COVID-19, is a virus that binds on the ACE2 receptor. So not just in the lungs, actually we have those receptors in our colon and in the liver. So that's why some of the COVID patient, they have kind of GI symptoms, they have nausea, vomiting, diarrhea. So you're thinking, okay, our liver has this ACE2 receptor. It probably can affect the liver too. So they say actually fairly common in hospitalized COVID patients, but of course depends on the cohort you look at, can be 14 to 60%, you can see. But in general, for someone just have very mild COVID, they probably had no or minor like liver enzyme abnormality. Usually we see more higher liver enzyme in those patients more like admitted with more severe COVID disease, or like in ICU patients, quite often we see a little bit high liver enzymes. So how does COVID affect the liver? So there's a lot of proposed mechanism. They think because it's a virus, maybe attack on that receptor, so a direct virus effect. So maybe it's the body immune system try to fight the virus can cause some like elevated liver enzymes. So maybe that someone has some underlying pre-existing liver disease now got unmasked. But I guess quite common is actually the drugs we give it to these patients. Quite often, there's really, first of all, no good drugs. I look at the plasma and look at the antiviral, but quite often you can see they worry they have secondary bacterial pneumonia. So they put on really broad spectrum antibiotics. And we know quite often broad spectrum antibiotics can cause liver enzymes. And someone really sick, they not enough blood flow to the liver, we call them the shock liver. So basically kind of like angina, but it happened in the liver. So they had a period of time, the low blood pressure from the really bad like infections. So maybe it's due to that mechanism as well, or a combination. So far it's not remained completely clear, but a few potential mechanisms. Now, what do we know so far about COVID-19 in patients with chronic liver disease? There's kind of like conflicting data about whether a patient with stable chronic viral hepatitis, autoimmune liver disease such as PBC had increased more susceptibility to COVID. So some studies say yes, some studies say no. So still conflicting data. And quite often we see is the fatty liver patient because they have the diabetes, obesity, and you heard about those ones make them more likely to have more severe COVID. Now, in general, the Hep B and C, I kind of reassure a lot of our patients that, yeah, there's nothing to directly affect it. We don't affect the treatment. So we say most of the kind of maybe negative outcome is someone maybe delay going to have ultrasound, delay to have blood work. That's kind of we discover something later. So I don't think it's directly related to COVID, but related to the whole system about telemedicine and the bit lack of like direct patient care sometimes can indirectly affect those patients. And then we still recommend all the vaccines, but we'll go a bit further about talk about the COVID vaccine a bit later. Now, but I want to highlight that it seems like the stage of the liver disease does play a role about the survival from the COVID. So this is presented last year in the liver meeting. Basically, very interesting they look at, like compared to someone without cirrhosis. And then this is Child-Pugh A, B, C. We know that Child-Pugh C are the one really, really sick. So they say once they hospitalize, you can see the one with Child-Pugh C, so a 54% mortality. But as things go on, we know that even people without cirrhosis, when they need ventilation, they are definitely high mortality. So you can say CLD, chronic liver disease without cirrhosis, 21% of mortality. But when they have Child-Pugh C, they're very sick to begin with. And now with COVID needing to intubation and need a ventilator, the 90% mortality rates are really high. And then on the right, they look at like age seemed to play a role, and definitely the stage of fibrosis. And some reason they detected like alcohol. They don't know why specifically, but is this the only factor that shows statistically significant alcoholic liver disease seem to not do as well. And they look at other cofactors. They look at smoking, obesity, but you can see so far no statistic significance detected on the study. But keep that in mind, it's really like reports still ongoing, things will change. But at least we know, I think one thing really clear is the stage of the liver disease does play a role in terms of how well they do. This is another one they actually published in a journal. It's a small number, 50 patients with cirrhosis. But again, that's compared to cirrhotic patients. So you look at the graph on the top. So like the 30-day mortality, it is 34%, it's fairly high. Now the bottom, they kind of using MEL score. MEL score is a system, like score system we can depend on how sick of the liver dysfunction. Normally when someone MEL around 17, 18, there's enough dysfunction that we actually generally refer them to be assessed by liver transplant. So they use basically, over 50 means kind of sicker liver disease. Less than 15 is like really mild. but they could be even 14. It's still advanced disease, but not quite needing the transplant assessment. But you can see the cutoff 15 seems to show there's a high difference in the mortality. So from 22 versus 69%. So again, kind of consistent with the other studies that, yeah, the more severe liver disease someone has, if they have COVID, they likely not do as well. Now, predictors of outcome. So basically, not surprised is again another study is like if someone the underlying cirrhosis is due to alcohol, they seem to not do as well compared to other liver disease. And then the middle graph show basically is from someone no cirrhosis do fairly okay. I mean, versus the one with compensated, they still kind of very close, but clearly the one that have decompensated cirrhosis, they're much higher hazard ratio, not doing well. And again, if someone had hepatocellular carcinoma, again, they clearly not do as well compared to someone without the liver cancer. So in general, I think this can be summed up very nicely. So if someone has cirrhosis and have the COVID, put them together, they really have increased risk of ICU admissions, all the decompensation like bleeding, ascites, including even like renal failure or all the stuff. So it just means cirrhosis is not good. They have poor prognostic factors. Now, this one very interesting because when I try to do search, I'll hand it to Ed very soon, is to look at PBC and COVID. And very interesting, they have case report. I actually find two. They said, oh, just an example. So this is published very recently. It's a 44-year-old female of a history of thyroid disease. No known any liver disease to begin with, but she developed PBC and then Guillain-Barré during COVID. So they follow this patient and they notice like high alkaline phosphatase, like GGT. So end up they have to do a liver biopsy and confirm all the typical stuff like florid duct lesions and the AMA come back. So probably in this person, she does have some autoimmune because she has thyroid disease, like some genetic predisposition, maybe had this viral infection, which is the COVID as a trigger, then developed the PBC. So we think maybe this is the reason, and maybe the COVID activated immune system causing this condition, the PBC. So very interesting that like COVID induced like a first presentation of the PBC. Okay, so I'll hand it into Ed to talk about efficacy and safety of COVID, the vaccine in chronic liver disease.
Thanks, Hin. That was great. All right, let me just get these slides up again. So I'll just move on and chat a little bit, just continuing on the thread of COVID and the liver and talk a little bit about vaccines. I think Hin and I and all of our colleagues have been getting a lot of questions, understandably, from people who are trying to navigate the whole situation around COVID-19 vaccination and chronic liver disease. And so hopefully we can just open up the discussion here and then leave lots of time for questions around it. So this is just a quick table looking at an overview of the 4 Health Canada approved COVID-19 vaccines as of now. So even as of today, that hasn't changed. And so really there's 2 broad categories and there's 4 Health Canada approved vaccines right now. And the 2 broad categories, we have the Pfizer and the Moderna vaccines, which are mRNA vaccines. And then we've got AstraZeneca and Janssen, which are so-called viral vector vaccines. And we'll talk about that in a little bit further detail. Obviously, this table has a lot of information in it, but really, you can always come back and reference this table. And of course, there's similar resources on the internet elsewhere. But the take-home message here is all 4 of these vaccines are safe and effective. And that continues to be the case and the understanding in the context of chronic liver disease as well. And we'll talk about that in detail. But again, I think the take-home message here is that we've got multiple options and they are all effective and safe. Now, in Canada, we haven't taken delivery of any of the J&J or Janssen vaccine yet, but that's expected in the coming weeks. And as you're aware, I know there's people tuning in here across provinces, and the approach to vaccine rollout is a little bit different across provinces, but in all of our provinces, to some degree, there's the availability of Pfizer, Moderna, and AstraZeneca vaccines. So when you look at the types of vaccines and how they work, this is just a general, just pictorial overview to give you a sense of, the mechanism of action here. And really, you can divide them between the mRNA and the viral vector vaccines, as mentioned. And in general, the concept here is very similar. So unlike traditional vaccines, which typically may use whole virus to generate a person's immune response, these vaccines for COVID-19 focus on a specific part or protein of the coronavirus, the spike protein. And so scientists were able to isolate the gene that codes for the spike protein and to use that information essentially to, in a different way, depending on the type of vaccine, provoke an immune response in any given individual to that spike protein and eventually cause immunity. And so if we look at that in a little bit further detail, but I'm not going to go into too much of the nitty gritty, but just to give an understanding. So if we look at this picture here with mRNA vaccines, again, you think about the ability to understand that the the COVID virus has the spike protein on the surface. You can isolate the messenger RNA, or basically the instructions for producing that spike protein. And in the case of an mRNA vaccine, that mRNA is put into a lipid nanoparticle vehicle delivery, injected, taken up by antigen presenting cells, and basically that leads to a body's immune response to create antibodies against that protein. And so for that individual, once they're vaccinated, if they see that virus and see that spike protein on the outside of the virus, there's a robust immune response and vaccine acquired immunity. So these statements here are specific to BC, but of course are in general generalizable across Canada, and Pfizer and Moderna being mRNA vaccines, both being used for an age-based cohort rollout of vaccination here in BC and continue to be so. Obviously, we understand that there's been supply issues as we go along, and right now Pfizer is kind of the backbone, as people have been describing it, from a supply perspective of the vaccine rollout in an age-based cohort. The viral vector vaccines, again, that's AstraZeneca, which is available right now, and Janssen, which is Health Canada approved, but not yet in use in Canada. Again, a very similar concept, except in this case, we're looking at DNA that codes for the spike protein that is incorporated essentially into a viral vector. And in this case, the viral vector is an adenovirus, or a typical virus that might otherwise cause a common cold in an individual. But the viral vector that is used for the purposes of a vaccine needs to be something that humans haven't seen frequently. Otherwise, as soon as you inject it into an individual, the viral vector itself would be destroyed and you wouldn't get the desired effects. So in the case of the viral vector vaccines that are being used for COVID, they're using adenoviruses that are isolated from chimpanzees, something that we haven't seen in humans. And the important thing to understand is that these viral vectors, they are benign. They are altered such that they do not have the ability to replicate. And so it really is just a viral, basically shell or vector to deliver that DNA to, once again, antigen presenting cells that will produce the spike protein and provoke an immune response. So really, again, just a different technology, a different method of delivery to provoke an immune response against that spike protein of the COVID virus and to produce immunity. And so as you can see, there's two of these viral vector vaccines. AstraZeneca, obviously, there's been so much about it and changing guidance, and it's a great vaccine, but the messaging around it, and I think how it's rolled out, has been a little bit bumpy, and we've seen that. And so it's led to a lot of questions, about the safety in particular. And we'll talk about that a little bit. And, right now, as you've seen, even the guidance for AstraZeneca has changed significantly over the past week. Now the age cutoff being dropped once again, and perhaps will continue to be dropped, and will change in jurisdictions across Canada as we move forward. But when we think about now all of those 4 available COVID-19 vaccines, and I said, I made a broad statement at the start that they're all effective and we believe that they're all safe. And so, of course, it's important for us to address and to try to understand, well, on what data do we base that kind of statement? And obviously, in any kind of emerging field, we have to kind of do our best, because we can't answer all the questions that we want with robust and large data sets. But if we look at the clinical trials data for some of these vaccines, we can at least understand which of those clinical studies included individuals with liver disease. And as you can see, both the mRNA vaccines did have individuals with liver disease in them. And in the Janssen study, also they included people with liver disease. One of the things, and as you can imagine, the focus of these studies was really to look at the overall effectiveness or efficacy and the safety of these vaccines. Specifically looking at liver disease related outcomes was not a focus of the clinical study design. And so for that reason, although they knew it was important to include individuals with liver disease to some degree, as you can see, the overall percentage of individuals affected by liver disease was low, but there's still a meaningful number, as these were large studies, a meaningful number of patients with liver disease who were included in these studies. As you can see, when it comes to liver transplantation, Really, the only study that included individuals post-solid organ transplant was the Janssen study, and that's a very small proportion of individuals. But otherwise, you had a meaningful number of patients with liver disease, and we understand that in the clinical studies, no concerning safety or efficacy signals came about in those individuals with liver disease who were included. But of course, there continues to be some outstanding questions that we'd like to try to answer, and we're going to have to answer in the real world, such as the magnitude and duration of vaccine response in individuals with chronic liver disease, whether that varies based on disease severity. Hinin very nicely outlined the difference in the clinical course of COVID in individuals dependent on their liver disease severity. So it only follows that it's possible, as is the case with other vaccines, that liver disease severity may also impact response to vaccination. Things like risk of liver injury and the durability of response post-transplantation, these are things, again, that we're learning more about in the real world. Obviously, these vaccines are being rolled out globally and very quickly, so we're going to see more and more of this information getting published. But there are a number of unanswered questions which we understand. If we come back to that overview table, the thing I want to emphasize once again is we understand that mechanisms of action may be a little bit different. The way they were studied may be a little bit different. But when you look at the overall efficacy of all these vaccines, they're all very, very effective. And most importantly, almost 100% effective against preventing severe disease, which is what we're really trying to do here. And so I think that the take-home message, and obviously we're getting this question so frequently, patients, asking us if it's safe to be vaccinated, if it's advisable, and the answer almost always is yes. There may be very, very select circumstances where a caution is warranted, but for the vast majority of individuals with chronic liver disease, we understand that not only is vaccination safe, it's important, in particular, magnified in importance if you have more significant liver disease, as you may be at increased risk of more severe COVID. Now, to take a step and to talk a little bit about COVID-19 vaccines and blood clot risk, obviously this is a topic that's come up a lot. And I would say about half the questions I'm getting from patients is really related to this topic of blood clots and specific to the AstraZeneca vaccine. Thrombosis Canada, if you haven't heard of them or haven't visited their website, obviously is a Canadian information resource that's medical data driven. That really aims to put out some clear messaging about the COVID-19 in the context of thrombosis. A really nice resource. And this graphic is from Thrombosis Canada, highlighting the very, very low risk of this very rare blood clotting disorder that has been observed in AstraZeneca vaccination. Now, you may have seen some more recent UK data that may have suggested this number is a little bit higher than 4 in a million. But whatever the specific number is, it's going to depend on the specific population, but it is very, very low. Contrast that with the risk of blood clots in the average Canadian or in birth control use or in hospitalized COVID patients. And so this, I think, is a very simple and effective graphical representation to help us understand what the true risks involved may be. Now, it is true that in this graphic, they're kind of lumping all blood clots together. And just, to be very specific about it, when we're talking about blood clotting and AstraZeneca, really we're talking about this very specific entity of vaccine-induced prothrombotic immune thrombocytopenia. That's a mouthful, or VIPIT as people call it. But the reason I think it's important to bring this specific topic up is, again, with this vaccine, it's very, very rare, and it's a specific type of blood clotting disorder. And it does not appear that a prior history of thrombosis or DVT or family history of thrombosis or DVT increase in individual risk of getting this. So I get that question frequently as well. Individuals who wonder, well, I've had a DVT before, or somebody in my family has had a DVT before. Is it still safe for me to get the AstraZeneca vaccine? Oh, and by the way, I have chronic liver disease, of course. So it's important to understand that, fortunately, at least at this time, it doesn't appear that those factors influence the decision to advise that AstraZeneca vaccine remains safe. And so this is a general flow chart that kind of points out how, from a medical perspective, we're asked to approach individuals who may have this condition. And I bring this up not to talk about it in detail because it is so super rare, but I think it's important from a patient perspective for you to understand that physicians are thinking about this. We're aware of it now. And although it is extremely rare, physicians are are aware of it and looking for it and know what to do. And I think that's one of the more important aspects of this as well, is that for a very, very rare outcome, that the education is out there from a public and a practitioner standpoint to look for it. So just along the same lines, and not to kind of beat this issue into the ground, but you can again look at a comparison between the chance in a million of serious harm due to vaccine side effects and compare that to the things they're trying to prevent, like dying with coronavirus, right? Or, day-to-day risks associated with being in an accident or other injury. And you can see, the risks associated here when we're talking about vaccine-associated risks are very low. And that is why when you hear the guidance that's being put out, whether it's from NACI or, any provincial or national organization, it's all about talking about the risks being far outweighed by the benefits of these vaccines, which is very, very true and continues to be true also in the setting of chronic liver disease states as well. So a lot of questions have come about, and this issue kind of, essentially has just kind of, I would say, finished up as far as letters going out to individuals who are identified as clinically extremely vulnerable. And there's a lot of questions up front as far as if individuals with chronic liver disease in general would be identified as clinically extremely vulnerable. This is the list of essentially the clinical considerations and the categories of individuals who are prioritized for COVID-19 vaccine in British Columbia, to be specific. And so this is specific to our province. I know the rollout has been a little bit different in other provinces, but BC specific, of course, because this is where we're practicing. This is kind of how they've done the rollout here. And as you can see, there is no category specific to individuals with chronic liver disease. And I think based on what Hinian showed you, you could make an argument one way or the other. We know that individuals in particular with cirrhosis and more advanced liver disease may be at increased risk. But then you kind of have to factor in all the other conditions that may be at-risk conditions and how you identify individuals. Here in BC, this is the list that was produced. Individuals as of mid-April were to have received a letter if they were in this category, and certain individuals with chronic liver disease would be captured here, but not all. The fortunate thing is, hopefully, as we see the vaccine rollout, get quicker and quicker, prioritization will become less of an issue, and we'll see more broad access in general, so that we just get to everybody as soon as possible. So I'm going to hand it back to Hin just to summarize to end, and then I think we'll take some questions.
Thank you, Ed. This is excellent, much clearer than sometimes what you heard on the TV. So I'm going to finish it off here, touch about the vaccines. Well, let me try to share properly. Okay, so what we know so far that, whether someone's more vulnerable to get the infection, I think it depends on more than just the underlying liver disease. Definitely play a role, but other comorbidities, other medication, I think what we think is the prognostic factor we highlighted is the cirrhosis. The more severe liver disease the person has might have that. If they get the COVID, can have more severe presentations. Now, kind of the most important factor in terms of vaccine to work is, again, the stage of fibrosis at the time of immunization. I think not just the COVID vaccine in general. We think in cirrhosis or patient with cirrhosis, the response to vaccine, maybe there's some immune dysfunction. So maybe the response to the medications, also the vaccine might not be as high as someone without the cirrhosis. So I guess we're waiting to just look at more data. But again, from all the vaccine trials and all the stuff so far, as Ed mentioned, all the vaccines seem to be safe, no specific safety concern we are aware of. And then, so just want to highlight this is the recommendations. I take out from the EASL position statement about say, yeah, we recommend the COVID vaccination for all patients with chronic liver disease and even with the liver cancer. So they have, of course, this is just what they think who should prioritize to get the vaccines. Of course, depends on the provincial, all the rule, but in general, patient with cirrhosis, because we know that if they get the COVID, they tend to not do as well. So all the liver decompensation. Patient with hepatobiliary cancer or patient with chronic liver disease, but they have other risk factors that can have severe COVID. For example, they have diabetes, a little bit overweight, and liver transplant. So among the chronic liver disease patients, those 4 group of patients we think should get prioritized to get the COVID vaccine. So in summary, then we open up for questions, and we know that PBC is autoimmune cholestatic progressive liver disease caused by genetic factors and some environmental triggers. So usually quite progress slowly, but sometimes the progression can vary, especially if someone had other maybe factors that can drive the progression of liver fibrosis, for example, alcohol, overweight. So we have to look at other factors. Now, it's very important to make the diagnosis early and also start treatment early, because you can see that even delayed treatment can show that the survival curve is not quite the same as someone who got treated early. And when they're on treatment, we do want to monitor the response, like specifically checking the alkaline phosphatase, the bilirubins. Now, we know that ursodiol has been quite effective for many patients for many years, but if we follow them, this could be still a small proportion that don't benefit and don't benefit completely just from ursodiol. And we need to think about additional agents such as the cholic acid. Now, to end, we mentioned that COVID vaccine would definitely recommend it for all. And just like anything, there's some risk, but you look at it in perspective, like COVID itself, as Ed mentioned, there's a high risk of blood clotting as well too. So in general, so far, we didn't see any concerning signal when using the vaccine in patients with chronic liver disease. And some of them, especially the one with cirrhosis, definitely should get the vaccine because they tend to not do as well if they got the COVID. So that ends our talk here. So let me stop sharing. Then we kind of open for questions. Right, Gail?
That was great. Once again, I've learned so much and presented in such an understandable manner, but with the science behind it. So thank you so much for that presentation. We have a lot of questions, and some of them I think you've answered within the presentation, but they're kind of specific. So I'm going to, throw them your way. I think they're answered, but maybe you can just repeat the short answer for this. Lorraine has had PBC for 27 years, and she's responded well to urso. But for the past 2 years, she's had some issues with blood clots. So would the vaccine be safe for her? She wants to know.
Yeah, I can take that one. Again, the specific circumstances, obviously in a forum such as this, we don't know all of the medical details present. So I'd always encourage, a good discussion with the family physician who can always direct, further follow-up with your subspecialist as indicated. But again, the general concept of whether a prior history of blood clotting would exclude you from use of, say, the AstraZeneca vaccine, that is not the recommendation right now. So we do believe it remains safe in general, as a general statement, even in the presence. And if you go to Thrombosis Canada, they make a specific statement about that. They talk about individuals who are currently on blood thinners and how they should remain suitable candidates for that vaccine as well. And so it's a great resource. And I think going to that website and using it as a resource as a jumping off point to engage the specific practitioners involved in your care and discussion is always important. That would be my recommendation, but always, again, important to discuss it in the context of your specific medical details.
Mm-hmm. I can post that website on our Facebook page so people can have a link there.
Right.
Here's a question. Does COVID vaccine pose any long-term side effects?
I mean, from what we know, of course, it's been just around for a short period of time. I think it's so far from all the observation, all the stuff, we haven't seen any long-term effects. I think we see definitely long-term effects from the COVID itself. So I think based on what we know, Ed can add that I don't think we are aware, but again, still too early. We just start vaccinating a lot of people like just the past few months. I think eventually you might hear something, but I think so far we really don't see any concerning like potential side effects from the COVID vaccine.
I agree. Yeah.
Okay, I have some now more general PBC questions from the beginning half of the presentation. So not COVID related, but this is a question that Isabel asks, and we get this question often. Should I have my children tested for AMA positivity?
Yeah, so it is a very good question because we know it's genetic. So very likely that the kids can have. Normally, I don't recommend just to check everyone right away. We think more likely happen in the females, maybe the daughters. We say, well, maybe get a checkup for like the liver enzyme, but when the liver enzyme got like elevated, especially the alkaline phosphatase, then consider that the possibility of the PBC, then I do the blood work. because those immune markers are very not specific, especially even the ANA. AMA is a bit better, that it can be potentially positive in the normal population. And furthermore, we see quite often, Ed probably had the referral that we have someone had positive AMA done, but liver enzyme completely normal, the alphos completely normal. And we do the IgM was negative. And then we said, well, could this someone be in the future develop PBC? I think there's still a study question we haven't been able to address. I think it's something we said potential. That means maybe genetic predisposition to something to monitor over time. So I would say the liver enzyme. I wouldn't jump to do the AMA right away, because I worry that nowadays maybe the protection for what I tell my patient about is like insurance. When someone just got regular tons of blood work, you're bound to have some abnormal blood work. And I just worry that, they get in the hands of you buy disability or life insurance, they will go into like long process. So I don't. But I'm curious to see what Ed also tell.
Yeah, I agree with everything you said. That's really my approach as well. I think I don't ask, first degree relatives to have their AMA tested, because again, it's possible to have AMA positivity in the absence of any evidence of chronic liver disease. And you don't want to diagnose somebody with a disease that they don't have, and beyond insurance implications, it can be, just provoke unnecessary follow-up and additional testing that's not required, more frequent testing that's required. I think, again, screening liver tests is reasonable. I think you can make a case for most individuals that screening their liver enzymes, it's pretty reasonable, whether there's a family history or not. But otherwise, my approach to autoantibody testing would be the same as in here.
Okay, thank you. Another question we have from Mary is about vitamins. You mentioned calcium, vitamin D. I have a couple of questions to add to Mary's. She wants to know if you would recommend other vitamins. And my question is also, do you recommend patients get that vitamin D blood work test once every couple of years, or just take the vitamins?
Interesting. I'll go first. I personally, I only recommend vitamin D consistently. And then again, calcium, typically quite consistently, but sometimes dependent on, how much detail we understand from an individual's dietary intake of calcium, whether it may already be sufficient. So I personally don't go beyond that, but I'm curious to know if Yin prescribes other things. And I don't routinely do vitamin D levels in my patients as well. Typically.
Yeah. I agree with Ed. I think about the fat soluble vitamins, so D is usually the one I recommend too. I guess most of them is our female patients diagnosed in the age that they probably more prone to get osteoporosis. So usually go to get all calcium, vitamin D. I think in general, I start doing some, but not on a systematic process to do. I may check one time vitamin D level, because I find that if I check myself, probably is low too. But I think in general, we're not getting enough sunlight. Well, vitamin D level, most people argue to take 1,000 to 2,000 for general population. So I'll check it once to say low, then ask them to take a vitamin D supplement. Then I don't think there's any particular guideline to check again. If people say, I've been taking for a while, should I check again? So I don't think there's some systematic way to check it, but sometimes I do check it, but not routinely.
Okay, we're over our time, but if you can stay for some more questions, I have lots more questions coming through. Now we're back into the COVID area. Is that okay?
Yeah, sure.
Okay, great. So these are sort of more research related on the COVID. So is anyone tracking COVID outcomes in the PBC population to see if any alarm bells are being rung?
I'm sure someone is. I don't know if you know specifically who's doing that right now.
Yeah, I'm not sure the Canadian we're doing, but I know nationally they look at the cohort about, I know from measles or even AFC to look at patient put in data. Say if you had a liver patient with COVID, just to see the outcome in general. I'm sure some of them will compromise, or compose of some of the PBC patients. So I'm pretty sure someone definitely look at chronic liver disease, and I think small percentage will be the TBC patients.
So that may come out in a few years.
A lot of studies that are being published around COVID are relying on large health databases, that rely on health-linked, diagnostic codes. And so I think actually you'll see some of that data published, probably sooner than then, as people have the time to aggregate that data, as it is. Yeah, it'll be important data across liver disease states. Yeah.
That's great. We have a question here. Have you heard anything out of France or Israel about giving a third vaccine shot to transplant recipients?
I haven't heard about that approach myself.
Yeah.
Most of the clinical practice variation that I've encountered, just kind of looking into this topic further, is just about the timing of COVID vaccine doses around post-transplant and immunosuppression. And typically it appears that different centers have their own protocols. I haven't seen anything about additional doses myself.
Yeah. Yeah, I haven't seen anything. I mean, people even argue to say that there's so many variation. Not sure it's true. They say, well, eventually maybe we need kind of a vaccine just like flu shot every year. So potentially that's, I think, yeah, same as Ed. I'm not aware of like giving the third dose of the transplant. Probably just something investigational, I guess, if they decided maybe based on the antibody level, but I don't think even listed as one of those on the monograph of those vaccines.
Right.
So I guess this is a Canadian question. Any thought of getting the second one before the 4-month? I believe in Ontario, I think that's a supply issue. I don't think it's a prescription issue.
Yeah, I think so. I mean, I think probably they look at I mean, the BC, they plot some data to say the BC CDC, they say, oh, probably even up to 4 months, they think is supposed to be effective. But I think it's based on small number. You really have to look at the antibody levels. But I agree. I think it is still the supply issue. They want more people because you can argue with some studies say you got the one shot, you're probably 80% protective. And then get the second shot, maybe, let's say ideal, 90%. So, but then you can use this one extra dose rather than saving for someone had the second dose to give more bigger populations. So most people, at least 80%, then maybe small cohort 90%. I think it is just to get more people vaccine. It is, if you have unlimited supply, I'm sure we're getting it more according to the research that when they do the study. So I think it's the same issue, but whether it works, I mean, it's hard to know. I think whoever make the 4 months and nasty, the committee, they probably based on some data to suggest it's probably still within safe limit to give it within 4 months.
Okay, I'm not sure we can answer this, but it's an interesting thought. I read that, Diana says, I read that people with autoimmune diseases not having full protection from the vaccine, and we should not wait 4 months. Have you heard of this, she says?
I haven't seen any good data to suggest that the approach will be different in that clinical context. And so specifically thinking of, say, our individuals with autoimmune liver disease, there's not really any firm guidance around changing their immunosuppressive regimens or changing the overall vaccine strategy. And as Hin pointed out, some of this is dynamic, and it's not just about what's medically the ideal. You have to take it to the real world and based on what we can actually roll out and what our supply is. But I haven't seen any data to suggest there's significant concerns in that context.
Okay, so in the presentation, you mentioned the different risk factors for COVID making it worse, I believe, and fatty liver was one, was it? Yeah. And so I'm just wondering, before that you presented that, I had a question down here. Why should people with PBC be concerned about fatty liver in general? And are we more susceptible than the average population or the general population to get fatty liver? And what if people with PBC do get fatty liver? And then I guess now the COVID implications you've pointed out.
Yeah, I mean, fatty liver is very common. So it depends on different parts of the world. It's range from 25 to 30%. Anyway, so regardless what other comorbidity you have, so quite often we can see fatty liver also exist in our PBC patients. So I guess if someone had fatty liver and the PBC, I mean, they didn't highlight fatty liver per se increased risk, but I guess it's linked to the diabetes because one of the risk factors for fatty liver is the diabetes, the obesity. Not necessary. People can have fatty liver even though they have no diabetes and not even overweight. But I think it's the other risk factor make them have fatty liver disease that make them more likely to can get more severe COVID. But to get back to the question, is very common. I think quite often I'm now seeing like, the fatty liver, exists with hepatitis B, exists with hepatitis C, so come with other liver disease. So when someone maybe not have a good response to the ursodiol, I kind of one thing approach is like, well, maybe it's not just the medication, making sure I'm not missing other liver disease, such as the more common or the most common one, which is the fatty liver. They actually, even though you can flow in as much urso or even add OCA, it might not really, I guess OCA might can help a bit of fatty liver. So then you might have to really know what's driving it. So sometimes we might have to do a liver biopsy to see what is really driving this normal number. Is it the PBC or is it the fatty liver? So it become very complicated because now I think we see a lot of our patients like all my liver referrals, a lot of fatty liver disease.
Yeah.
Right.
So what would you advise patients with PBC to understand if they do have fatty liver and what to do about it, or how to know they have it?
I think a lot of it is about an index of suspicion, right? Like Hin pointed out, obviously we understand that not everybody with PBC normalizes their liver biochemistry on ursodiol or with OCA. But depending on the nature of the residual abnormalities or the overall clinical context, I think it's important, whether it's PBC or hepatitis B, to keep in mind that 25% of Canadians have fatty liver. So probably 25% of your PBC patients have fatty liver too, And although their risk isn't necessarily specifically increased because of their PBC, it's just super common. So the answer to that question really, honestly, it probably falls back to the practitioner who is monitoring that individual to have an open mind to understand that there can be other comorbid liver states that occur, and fatty liver is just super common in general. Yeah.
Okay, I think that's, well, I mean, I have 1,000 other questions written down, but I think we've covered the questions relevant to the presentation and certainly all of the ones I hope that were asked by our live audience tonight. And if we didn't cover it this time, well, hopefully you'll come back and cover it next time. So I'd really like to thank both of you. I always marvel at the work that our PBC doctors do. It's not just their clinical work that they do with, of course, seeing patients and helping patients, but it's the work you do in educating your fellow doctors, whether they're trainees or gastroenterologists or just general practitioners. The education piece that you do among yourselves is amazing. Thank you. And the education piece that you do for us, for the PBC patients, is so much appreciated, because we always find that patient knowledge is power, and a knowledgeable patient will have a better opportunity to live their best lives. So thank you. I hope to see you guys again. It was a great presentation. Thank you for showing up twice. And we really appreciate everything. Hope you had fun.
Yeah, we do.
Thanks so much.
Thanks everyone for attending.
Bye.
Goodbye.